So hello everyone, welcome so much to our first Neurodivergent Brain Body Clinic Psychoeducation session. My name is Jessica Eccles and I am one of the doctors in the neurodevelopmental service. I feel I have a very lucky job in that I get to spend 2 days a week in the neurodevelopmental service and 3 days a week at the university where I do brain-body research. And alongside colleagues Rebecca Dew and Hugo Critchley, we have set up the world's first neurodivergent brain-body clinic. All of you have been a part of it. And Anna is our clinic assistant, as is Ellie, is with us for a year and she is in the audience. And this is basically to try and help people make sense of some of the things that may have come up in the assessments that you have had. So let's see if we can move the slides on. So yeah, before we do move the slides on, actually, I'm just going to make sure that my phone is do not disturb. Absolutely. Okay. So the other thing is if you want research updates, please follow me on Instagram or Twitter. I know there's not many people left on Twitter now, but on Instagram, I'm Dr. Bendy Brain. Okay, so I was just going to start off by telling you a little bit about why I'm interested in the brain-body connection. So I have, during my medical career, I have been fortunate enough the whole time since graduating from medical school to have pursued research alongside my specialist training. And my specialist training in psychiatry has been both related to neurodevelopmental conditions, so ADHD, autism, Tourette syndrome, but also something called liaison psychiatry, which is the relationship between the brain and the body. And I have been particularly interested in the concept of this, this idea of something called hypermobility. And that is because as a medical student many years ago, I think probably in 2004 or 2005, I was on a ward round doing my orthopedics rotation. And one of the doctors said to me, I think you have sway back knees, you are hypermobile. And at the time I was in a lot of pain from a hypermobility related condition that causes early arthritis. And instead of doing a particular rotation, I was sent on a pain rehabilitation program. So the main thrust of the work that we've been doing at Brighton and Sussex Medical School really is about the brain and the body being inherently linked. So I am fond of this particular newspaper article that basically says the big idea, should we drop the distinction between mental and physical health? Because the current false dichotomy, so the false distinction between mental and physical health, holds back research and stigmatizes patients. I would also go so far as to say that the current false distinction really affects clinical practice. And that is what we try in the Neurodivergent Brain Body Clinic, is to join up the dots between both mental and physical health. So that was me as a medical student back in 2004, diagnosed with something called joint hypermobility syndrome. And actually, a lot of the work that we've been doing has been about hypermobility. And one of the things is hypermobility is accessible according to the joints. So as you can see, it's things like being able to put your fingers up like this, or be able to bend your thumb back onto your wrist. But hypermobility is so much more than party tricks. And there are lots of people think, oh, I'm quite stiff, I can't be hypermobile. But there are so many other features that are important to discern. So let's go on to the next slide. So one of the first things that I got interested in hypermobility about was anxiety. So when I first came to Brighton and Sussex Medical School, Hugo Critchley, who is one of the other clinicians in the neurodevelopmental service, he told me that there were some Spanish researchers who had been looking at the link between hypermobility and anxiety. And they had found that if you took a room of 100 people with panic disorder, 70% of them were hypermobile, compared to less than 20% in people without panic disorder. And this really made us curious. What is the relationship between hypermobility and anxiety? And it sounds bizarre, but there were some interesting articles about how hypermobility was actually related to increased fear sensitivity and increased chocolate consumption, which the authors at that point thought, oh, that's maybe self-medication of anxiety. But I now wonder whether that's self-medication of ADHD symptoms in part. And the same thing with increased tobacco and alcohol use in people with hypermobility. So I spent my PhD trying to work out how you get from having flexible joints to having a panic attack. And what we found was that people with flexible joints had differences in an area of the brain called the amygdala. Now, the amygdala is part of the brain that is responsible for fear and emotion processing, and it is also linked to the involuntary nervous system, so the flight and fright nervous system. And the thing about hypermobility is a difference in the connective tissue of the body. So the connective tissue of the body is the collagen and the connective tissue proteins that are everywhere, like a cling film. And that cling film is present throughout the body. And that is why people with hypermobility are more likely to have certain physical health problems. And one of the things that we were interested in was this relationship with something called postural orthostatic tachycardia syndrome. Now, postural tachycardia syndrome basically means that you have a heart rate rise on standing. That means that you might feel dizzy or lightheaded. Interestingly, it also happens to some people after they have a large meal or after they have a hot shower. They might feel that they need to lie down. And although there are many things that could be potentially causing postural tachycardia syndrome, one of them is that the floppy connective tissue in the blood vessels means that when you go from lying to standing, that blood pools in the feet and doesn't go to the head, leading to the dizzy feeling, but also the body has to maintain the cardiac output, so it pushes up heart rate in order to maintain blood supply. So postural tachycardia at an extreme is diagnosable when you have an increase in heart rate from lying to standing of 30 beats per minute. And some of you will be coming into the clinic to have screening tests for this. So we wrote a paper about how hypermobility is potentially linked to panic through this mechanism of postural tachycardia syndrome. We also published last year, we looked at a large birth cohort. So that was 6,000 children who were born in Bristol and Bath, Bristol and Avon in the 1990s. And we tracked them. And when they were 14, if they were hypermobile, they were more likely to experience anxiety and depression at 18. And this was in part related to a higher heart rate. So we've also, we're just having under review at the moment a couple of brain imaging papers further exploring the link between hypermobility and anxiety. And we think that in part it is to do with this autonomic difference in terms of that's the involuntary nervous system to do with the postural tachycardia mechanisms. So what are we going to talk about today? We're going to really focus in on the relationship between neurodivergence and hypermobility. So as you know, the traditional view is that neurodevelopmental disorders are discrete, that you have one, that this is very deficit-based. And we really are, when I was at medical school, which was a while back, we were taught that such conditions were relatively rare, disabling, disruptive, and that they were diagnosed in childhood. It was generally assumed that children grew out of things like ADHD, and if they didn't, they ended up in prison and certainly didn't have jobs or relationships. We were told that these conditions were discrete and that they were strikingly more likely to affect males, for example, by up to 9 times. We were told that many people diagnosed with autism lacked empathy and theory of mind, and that most of them had a learning disability. We know that this is not true. We know that gender stereotypes are complex and a challenge, and that we see in our adult clinic far more women and non-binary people than we see men. We know that empathy and theory of mind are present, but are perhaps different. And we all know that neurodivergent communication is not necessarily inherently disordered, but rather that it's about finding your tribe. And we know from research that neurodivergent people can communicate very effectively with other neurodivergent people. What we've also found, and what this talk is really about, is that co-occurrence is the norm rather than the exception, both in terms of having other neurodivergences, but also in having certain physical health issues. Now, I believe that the language that we use is important, so I tend to use identity-first language. That might not be everyone's preference, but that's basically to talk about autistic people or ADHD people rather than with autism. But that is based on a general preference in the community, and others' views may differ. So the alternative view is that neurodivergence comes with both strengths and challenges, and that we need neurodiversity in the world in order to have exciting thinkers. And this is a slide from an organisation that I'm going to mention again, called SEDS Connective, who are a Sussex-based charity specifically looking at the intersection between hypermobility and neurodivergence. We also try and work in our practice in something called a neurodiversity affirmative way, and looking broadly at neurodivergence, not just at autism or ADHD or Tourette's in isolation, but really thinking about the sensory differences, the social differences, the need for sensation seeking, self-soothing and stimming, compulsivity, strong interests, executive function differences, and also preference for sameness, routine and predictability. So we know that ND people, so neurodivergent people, process information differently, that they are often overwhelmed by multiple streams of information, struggle to filter out non-important information, and are soothed by familiarity, patterns, and sameness. We also know that the autism spectrum, or the neurodivergent spectrum, is not linear. It is not a question of being less autistic or very autistic. It is a question of having different strengths and challenges in different areas. And this is a quote from a Twitter academic: "My spiky profile means I can easily give a complex lecture to 200 people, but I can't phone my doctor if I am ill." So we know that, well, I was taught that autism and ADHD affected men or boys rather than girls. And we know even in 2020 that if you give school teachers a case vignette and you put a boy's name on it rather than a girl's name, they're more likely to consider it for a referral, which is possibly why some people are being diagnosed late. But new research suggests there is in fact probably no gender difference at all. Also, research published by BSMS just 2 weeks ago from Hugo and my colleagues Lisa and Sarah suggests that autistic people, one of the myths is that autistic people and neurodivergent people don't need friends or don't want friends. But this they published a paper on loneliness, and really this is quite an important myth-busting paper. So what is the problem that we're going to talk about today? Well, we know that neurodivergent people are more likely to experience barriers to accessing healthcare, and also more likely to have adverse outcomes. Now, this could be for a variety of reasons. We know how difficult it is to get hold of the GP, and things like this are worse during COVID. Atypical presentations of pain, but also we think that that there are more likely that neurodivergent people actually experience more physical health concerns than the general population. So this is colleagues of mine, Sebastian Shaw and Mary Doherty, have written that autistic people live with more mental and physical health conditions, and on average die younger than non-autistic people. autistic people still report barriers to accessing healthcare. And people who took part reported a variety of barriers. Themes included earlier barriers, communication mismatch, doubt in oneself and from doctors, and healthcare avoidance and adverse health outcomes. People really struggling to be believed. Our findings allow us to create a model that aims to understand and explain these barriers in the context of the previously known consequences. So for us, working in Sussex in the neurodevelopmental service, it has really been a series of light bulb moments in terms of thinking about hypermobility. So this, and all of you will have gone and seen Anna and perhaps Ellie and had hypermobility assessments. This is just one way of looking for hypermobility. And the thing about hypermobility is it's so confusing. There are so many different terms used to explain it. So I like to think of you having hypermobility is the presence of hypermobile joints, and then symptomatic hypermobility is when you have medical problems that go with it. Now, Anna and Ellie will have assessed you, and there are all sorts of different ways to assess for hypermobility, but lots of people may go to the doctor or even a rheumatologist and be told that they're not hypermobile, but they may not have gone through a complete diagnostic workup. So hypermobility is more than just having flexible joints, as I explained earlier. It can, in fact, be advantageous. There are certain piano pieces that can only be played by hypermobile fingers, but it can also be linked to medical issues, including pain. And we know that hypermobility is actually relatively common. So it's linked to a variety of medical issues. And as I said before, these issues cross systems and involve both the body and brain. And it is confusing because there are so many different terms used to describe it. So there's things like JHS, which I was diagnosed with, HSD, HEDS, EDS3, EDS-HT. But essentially, if you are hypermobile, you're either hypermobile or you're hypermobile with symptoms, and those can change across the lifespan and in different contexts. So this is a slide from 2016, which is a little old, but it tells you how many things are associated with hypermobility. So flat feet, fibromyalgia, neurological problems like myalgia and dystonia, soft, stretchy skin, more likely to bruise with stretch marks, hernias, gum disease, resistance to local anesthetics. I don't know if any of you have been to the dentist and found that the anesthetic didn't work. A whole variety of gastrointestinal problems, so gastritis, reflux, irritable bowel, inflammatory bowel, food intolerance, Raynaud's phenomenon, postural tachycardia syndrome, irritable bladder, period pain, and urinary issues, vision issues, short-sightedness, squints, dental pain, temporomandibular joint pain, that's the joint here, difficulties with the flight and fright nervous system, like we were talking about, postural tachycardia syndrome, clumsiness, proprioceptive dysfunction, headache, fatigue, anxiety, sensitivity to pain, to sound, to sound and to smell. So all sorts of things are being linked to hypermobility, and even more every day. So things like allergy and neck instability are two things that are not on this list that should be. So pain and fatigue are some of the most common problems that people present to their GPs with, you can imagine. And we've been doing work at Brighton and Sussex Medical School, which basically was based on the idea that we think that certain types of pain and fatigue are related to hypermobility and are related to differences in the inflammatory system and the involuntary nervous system. So what we did is we were given money to study the condition fibromyalgia, which is where you have widespread pain for more than 3 months. And what we wanted to do was bring people into the hospital lab where people went on a tilt table to provoke the autonomic challenge, and we measured pain and fatigue. And we brought people into the brain imaging center where we we gave people either a saline vaccination, so salty solution, or we gave them a typhoid vaccination, which simulates a mild inflammatory challenge. And we did brain imaging before and after, and we did various blood tests. So what we found was that about a third of the patients came to us with a diagnosis of fibromyalgia, and a third came to us with a diagnosis of ME/CFS, and a third with the dual diagnoses. But actually, when we applied the research criteria, we found that 89% met the diagnostic criteria for fibromyalgia, and nearly 100% met the diagnostic criteria for ME/CFS, suggesting really that these conditions are overlapping. And what was really interesting from our perspective is we found that 4/5 of them, so over 80%, had symptomatic hypermobility, and that the hypermobility scores predicted fatigue and pain, including brain fog. So again, another light bulb moment in terms of the relationship of hypermobility to common physical health problems. So it's been traditionally thought that fibromyalgia and ME/CFS, ME/CFS is chronic fatigue, and fibromyalgia are non-inflammatory. But what we found was that if we asked, we did some basic blood tests that GPs do, ESR, CRP, these are non-specific markers of inflammation. We found that the patients had higher, significantly higher levels of inflammation than the comparison group, and that those higher levels predicted pain and fatigue severity. We also found that when we put people on the tilt table, you can see the patients in red and the comparison group in blue, that the tilt table induced pain in the patients, but not in the controls, and induced fatigue in the patients, but not in the controls. But interestingly, there was no change in pain thresholds induced by tilt, suggesting that the patients were in fact experiencing more pain, not that they were more sensitive to pain. So we spend a lot of time at the university wondering about causation and correlation. How do we go from one thing being linked to another? So we think about things as mediators and moderators. A mediator is something that is perhaps the mechanism explaining a relationship, and a moderator affects the strength and direction of a relationship. So what we found is that being a patient was related to having tilt-induced pain, and this was explained by hypermobility. And being a patient was related to tilt-induced fatigue, and this was explained by levels of inflammation. So I wanted to talk to you briefly about the findings with the inflammatory challenge. We found that the inflammatory challenge induced pain in the patients compared to the comparison group, fatigue in the patients compared to the comparison group, and that one of the hypermobility features was particularly interesting in terms of the relationship between the induced symptoms and the induced change in levels of inflammation. So what we find is that being a patient compared to being a control means you're more likely to have symptoms in response to inflammation, which is in fact linked to the degree of inflammatory responsivity in the system, and that relationship is explained by the presence of a feature of hypermobility. So we also did some gene expression, and we found that the biological processes, so this is not your genetic code, this is the proteins that are being produced at any 1 minute, were different between the pain and fatigue patients compared to controls, particularly in somewhere called the mitochondria, and that there was even a further difference in response to the inflammatory challenge, which was in pathways involved in inflammation. We did brain imaging, and we looked to see how parts of the brain talk to one another. And we found that if you were hypermobile, that the change in how the parts of the brain talk to one another induced by the inflammatory challenge was linked to the change in symptoms, and that was related to the number of hypermobile features. So we're also doing work, which is under review with a journal at the moment, exploring in a large database whether long COVID is related to hypermobility. And we know that about 50% of, up to 50% of people with long COVID have postural tachycardia syndrome. And we know that of people with postural tachycardia syndrome, probably 80% of them are hypermobile. So there's obviously something going on there, and watch this space in terms of our paper. So I wanted to say that the research I've just shown you, there was a huge number of people involved. So I want to say thank you to them. You may recognize Hugo, some of you who've seen him in clinic. But really thinking more back to how do we get from having connective tissue to having differences in connective tissue to having anxiety. I told you about the work that we did in terms of the brain imaging, but this is where it comes into thinking about neurodivergence. So when we did that brain imaging work, we found that there were differences in parts of the brain that had also been found in autism and ADHD. We also found that the more hypermobile you were, a smaller a part of the brain that is involved in where you think you are in space. And that was a possible link with dyspraxia. So what are the links between hypermobility and neurodivergence? So anxiety, dyspraxia. So this is very common that we hear that people, autistic people, ADHD people, have in their history difficulties with tying their shoelaces, difficulties with learning to ride a bike. They may be exquisite dancers, but bump into walls. They may be, able to do really fine crochet, but have difficulty catching a ball. So the relationship with dyspraxia, we know that there's overlaps with ADHD. And we also know that there are common differences in the flight or fright nervous system. So this issue of difficulties when you stand up, have a large meal, or have a hot bath. And there's possibly a shared genetic link there. And pain. Pain is a big common feature between hypermobility and neurodivergence. So we know we've been studying the relationship between hypermobility and neurodivergence since about 2009, but in 2016, they looked at the whole population of Sweden and found if you had a symptomatic hypermobility diagnosis, you were 7 times more likely to have an autism diagnosis and 5 times more likely to have an ADHD diagnosis. And colleagues such as Carolina Bieza-Velasco and Marco Castori have worked on a model trying to link how you get from hypermobility to things like autism and ADHD and dyspraxia. So we wrote a paper. It was actually in 2022 that it was published. It's now been seen on its website 106,000 times and is in the top 1% of articles ever published by this journal. And what we did is in the Sussex Neurodevelopmental Service, we specifically looked to see how many people were hypermobile and how many people had problems with the flight and fright nervous system and pain. And what we found was that neurodivergent people were much more likely to be hypermobile, and that this would explain the relationship with physical health problems such as pain. So I'm not going to dwell on it, but we took people coming to the clinic who consented to take part, and we ran them through a hypermobility examination, and we also asked them questions about their symptoms that happen to them when they stand up and when they have a large meal and things like that, and also about pain. And we had 109 patients, autistic patients, ADHD, Tourette, and we compared them to 57 comparison patients and also the 6,000 people in the ALSPAC birth cohort. And what we found was that overall, nearly half or more than half of our neurodivergent patients had generalized joint hypermobility compared to the comparison. And as you can see in the females, this is assigned female at birth, that nearly 80% of ADHD and autistic females had generalized joint hypermobility. We found that the neurodivergent group had greater physical health symptoms, and we found that those tracked with the number of hypermobile joints. We found that the neurodivergent group had greater pain symptoms, and that tracked with the number of hypermobile joints. So basically, this identifies the potential reason for the higher number of physical health problems in neurodivergent people, and hopefully can inform recognition and new management approaches. So again, what do we know? What is the link between these things? What is the mechanism? We find that neurodivergence is linked to physical health problems through the presence of hypermobility. So, pause, next steps. We're trying to work out why this relationship might be. So during COVID, we were working on a new treatment for anxiety, a non-drug treatment in hypermobility. And we found that all of the patients who were taking part were hypermobile. And we found that nearly 20% of them scored above threshold for suspected ADHD, and nearly 50% scored above threshold for suspected autism. And that the biggest contributor was sensory motor features. So as you can see, on the left-hand side, we have the sensory motor score from an autism screening questionnaire. And then on the right-hand side, we have the number of connective tissue features that are part of the hypermobility diagnostic criteria. And we can see that this is related to this process of something called interoception, which in Sussex we've been leading in terms of developing new treatments related to interoceptive training. The same relationship with ADHD and the number of connective tissue features. And what we are learning at the moment really is that there seems to be a relationship between neurodivergence, emotion regulation, and a sense of uncertainty about where you are in space. We're also shortly to be publishing on the relationship between ME/CFS and fibromyalgia and likely autism and ADHD. We're looking at, as I said, we're trying to publish on long COVID, and we are, this is what I was telling you about. Dr. Lisa Quat has been leading on the complex connection between neurodivergence and chronic health conditions. We're doing a project at the moment where we're looking to see about brain fog in the brain scanner. We induce an autonomic challenge in the brain scanner and look at blood flow. Our colleague James is doing a study about, it's just finished actually, about use of flotation tanks for fatigue. And our PhD student Beverly is doing a study about brain fog in pregnancy and menopause. So why, just before we finish and go to questions, why is it important to think body and brain? And that's because when we've talked to people, so there's a coalition of charities called Embracing Complexity that find that nearly half of neurodivergent individuals feel that their treatment of mental or physical health symptoms is worse because they were neurodivergent. We did work here in Sussex and found that neurodivergent people struggle for years to get an assessment and diagnosis for both mental and physical health problems, that they feel a strong sense of being dismissed, misbelieved, or overlooked when interacting with professionals and institutions, and that they repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education settings. And that is why we wanted to set up the Neurodivergent Brain Body Clinic to screen for hypermobility and neurodivergence. We would encourage our colleagues to screen for neurodivergence in hypermobility, and for us to really think to ourselves, are our environments, are our treatment programs, are our pain management programs, are they neurodivergent friendly and accessible? So please look out for upcoming studies. We will keep you posted. And the EDS UK GP toolkit is very helpful. If you are worried about children, the EDS UK school toolkit is helpful. And I would encourage people to link up with sedsconnective.org. So a big thank you to all of you and all of the participants who have taken part in our research, all of the funders, SEDS Connective, but a big shout out to Prof. Hugo Critchley Dr. Lisa Quat, and Rebecca Dew. So get in touch, find out more. You can follow me on Instagram at Dr. Bendy Brain. You'll see I was just in Parliament on Tuesday lobbying MPs about hypermobility, and I'm Bendy Brain on Twitter.